From quite a long time ago. I spent about a decade in hospital leadership in northeastern Wisconsin before I discovered I really preferred higher education and teaching. I taught for many, many years before I moved back into administration. So, excuse me. What I'll be doing this morning is laying some theoretical basis for ethics decision making. I'll move through that quickly, and then I have a couple of cases that come from my hospital background. As the hospital CEO, I chaired our ethics committee, and I was also one of multiple administrators. We always had an administrator on call 24/7 in the building. We were a regional medical center with level 2 trauma, and we had a flight program, so there was always something going on. So some of the cases come out of our emergency department, um, some out of the ethics committee, and I'll try to manage our time so that we can have some good participation. So I'm going to see if I can accomplish sharing my screen. I do have a PowerPoint that I'll share. So hopefully that is showing. Let me start the slideshow. I've got to get my tabs up here. There we go. Okay, am I showing properly there? Somebody give me a thumbs up if it's working okay. Uh-oh, I don't see any thumbs ups.
It's working all right.
Oh, okay, good. Thank you. So, excuse me. So I'm going to start with, boy, excuse me again. I'm going to start with some of the principles of moral philosophy. This is basically what guides decision making, and there are 4 theoretical lines that can be followed or concepts that can be followed. So I'm going to walk through those fairly quickly, and we'll end up down here at the very bottom of this slide in utilitarianism. So deontology is one of the 4 primary themes, and it focuses on the individual. It relates to motives rather than outcomes. So, if I am well intended, but I have a bad outcome, that's still okay under deontology. And it also includes some theoretical basis for the fact that there are certain things that we should not do, regardless of how useful they might be. So that's a real quick snapshot of deontology. Then there is a relativist perspective. And this we frequently see in many societies where ethical behavior is actually defined by the experiences of the individual or the group. So we think about things like murder in some societies versus other societies, that there may be, you know, permitted killings and so on. We differentiate between murder in the US being unethical and illegal, but if you're in the military and under command, combat's okay. So it is very relative to the values of others in a group. And one of the big things that you need to be aware of is that beliefs change over time. So at the risk of really dating myself, when I first went into my professional career, it was unethical for people like accountants and doctors to advertise. When I became vice president for planning and marketing, it was unethical for hospitals to advertise their services. However, it was ethical to do informational advertising and promotions. So we were a little bit hard to find off the main highway. So we did a lot of so-called directional advertising that happened to mention if you are trying to reach our level 2 trauma center, here's your exit, here's how you find us. Now, not too long after I started in healthcare, people, and I have to admit, I was one of them, began to push boundaries. Medical people began to push boundaries, the accounting profession. And after a certain amount of time, 5 to 10 years of pushing boundaries, the fundamental belief changed and it became acceptable. The professional standards were rewritten to allow for advertising and so on. So it is very relative. Virtue ethics are sort of more of an attribute that's defined by society. So if someone is trustworthy, if they show self-control, if they exhibit empathy, if they're fair and truthful, we consider that to be someone who is virtuous and ethical. And again, very much like relativist perspective, it varies by your societal definition. And so different societies value different attributes and would have a different sense of what is virtuous. We get to teleology, and this is very much an outcomes driven one, where whatever you do is considered morally right or acceptable if it produces the desired result. Now, at the individual level, that can be pleasure, knowledge, career growth, making money, whatever it might be. Early in the business era, there was a great deal of controversy about whether businesses should do anything that was socially responsible or whether their only obligation was to generate profit. And there was a saying that greed is good. Well, that would fit into this idea of teleology. And it relates to a concept called consequentialism, which is you assess the moral worth of whatever the behavior is by looking at its results. Now, that begins to get us where we're going to end up in our theoretical review, is that there's basically two approaches to this kind of teleological approach. That if you're looking at outcomes, if you're using a theme that's called egoism, that the right or acceptable behavior is for the individual. You are allowed under this concept to maximize your self-interest. And you look at consequences, you seek the alternative that benefits yourself the most. Then there is sort of the flip side of the same conceptual basis, and that is utilitarianism. And in this concept, you're seeking the greatest good for the greatest number of people. So it can be subjective, it can be objective, but basically you're looking for the greatest benefit for all of those affected by the decision. So back to that business model, we went in the business world from greed is good and looking out only for shareholders to much more of a socially responsible approach to business, which basically says that, look, you can do well in business and take care of your people and be socially responsible. And that gets under this utilitarian sort of thinking that you're looking for the greatest benefit for all, not just shareholders. This is also the primary thinking in the US in our healthcare system. If you think about how insurance works, you know, it has common procedures that are covered that are proven. The formulary generally is those pharmaceuticals that are pre-approved and that show benefit across a large population. We tend not to cover experimental procedures, newly developed things. We have a very intensive clinical trial process for doing that. So we do look at this greatest good sort of thinking around insurance plans, compensation, the whole way our healthcare system is organized. Um, this is the most prominent theory in this whole idea of consequence-based ethics. So your actions are right or wrong based on the consequences. And I mentioned a couple of authors here, Jeremy Bentham and John Stuart Mill, who form the classical basis for this kind of concept. So if you really are into moral philosophy, you could take a look at those authors. And again, as I said, it's to maximize good consequences, minimize bad. Now, to relate this back to healthcare and some of the fundamental principles, you are working on behalf of your patients to maximize good. The flip side of that is, above all, do no harm. So you're trained not to make things worse. You want to minimize bad consequences while you're maximizing good. And as I said, this is frequently used in healthcare, either explicitly through health plans or so on, or basically implicitly as people are making their decision. The emphasis is on the expected results. What that leads to is you're often trying to deal with competing needs, and you have to figure out what is the greatest good coming out of a decision. And that's part of what the hospital ethics committee did. So I'm going to move on to our next slide relating to moral reasoning, relating to ethics. You have those basic ethical theories. They're principle-based. They have different theories of social and distributive justice. And in the healthcare setting, you look at these concepts and you align that with issues like patient choice, conflict of interest. So, physicians cannot self-refer, and that would certainly apply to PAs as well. There was early in my healthcare career when MRI units were a really hot new thing. We had a radiology group that tried to establish their own MRI center. Well, that is a conflict of interest. And so there was a fair amount of pushback and back and forth before the hospital actually created a freestanding MRI unit near the local shopping mall. And it was the same radiology group that covered it and provided radiology services. So then you have issues of confidentiality. End of life decision making is always very challenging. And then working through decision making by surrogates. We have a fairly well structured system in many states, not all. That's one of the things that we have to always be aware of, is that we have 50 different legal systems because each state takes a somewhat different approach to the law and licensing and surrogates and decision making and so on. So taking this moral reasoning into a clinical context, you are being trained clinically so that you have an awareness of the basic course of common illnesses, the general prognosis, the general outcomes, the role of the healthcare team. A lot of your focus is being part of a healthcare team. So you understand the different professionals that are in the team and what their roles are, what their practice standards are, what the standards of care should be, and the basic healthcare terminology. And if you think about patient relationships, this last one is one of the key challenges. Is healthcare has its own terminology, and part of your role in the PA profession is to be that frontline interpreter for your patients. So a big piece of what you'll be doing is going to be patient education. In addition to these kinds of clinical issues, there is an organizational context. And this, again, is one of the things that you'll want to pay attention to as you enter into your PA practice. You have to look at the mission and values of the organization, the systems of care, the structure, processes for medical record keeping. And one of the things that I will urge you is that you make sure that your selected practice organization or location aligns with your personal values. Because I'll warn you right up front that if you're in an organizational context at any of our large systems, at the system that I led in northeastern Wisconsin, the organization's values dictated practice. And in those times, and there were a few along the way where we would have an individual practitioner, physician, PA, nurse, pharmacist, who says, I really can't support that, I won't do it. Well, then they couldn't work there. So we were a community not-for-profit regional medical center. We sort of friendly competition with several faith-based institutions. We had a Catholic hospital system in the region, so we had two different faith-based hospitals about 10 miles in either direction from our main medical center. So we were the only acute care facility in the region who supported things like reproduction control. We did a very limited amount of clinically appropriate therapeutic abortions in high risk cases. Well, some providers, some pharmacists, some nurses, etc., that's against their moral beliefs. And they generally did not work for us. And in the few cases where someone came to work for us and then tried to assert individual values, the organizational values overrides. So this is something that you're going to want to be very aware of as you make practice decisions. And then you'll want to be very aware about organizational policies and procedures, because again, you will be practicing under your PA practice standards, but you'll be doing it in an organizational context, and that will define how you obtain informed consent, how you deal with advanced directives, whether or not the organization supports withholding or withdrawing life-sustaining treatment. If it's a research institution, my hospital did a certain amount of research. You have to have all of the consents and an institutional review board for human subject research. You have systems for disclosure of medical errors, and every caregiver in the institution participates in that. So if there is a sentinel event, we expected that our PAs, our nurses, our physicians, and so on participated in open and honest disclosure, and then we could go and study it, improve improve our systems to prevent an adverse event. We also expected the same kind of performance around impaired professionals. And, in any large institution over time, you do have some. So we did have a highly trained specialty physician who had gotten into drugs during his medical school, could not shake it. And in our internal peer review process, I received reports from other physicians about concerns about impairment. And after some investigation, we did remove his hospital privileges, reported him to the state medical board. He ultimately mailed back his license, went into rehab, and I don't know what happened after that. But as you practice, this is a key piece, is to be aware of the organizational context and the fit of your value system to that context. Also be aware of cultural beliefs. So we had the first case that I just want to share very quickly, and then we can get into more discussions in a moment. We had the most active trauma center in the region, and we had a very active ER. So I happened to be the administrator on call one evening when we had an older woman present. She was non-English speaking, and we had a male physician on duty in the ER, and she was absolutely traumatized with his presence, was refusing care. Our staff could not understand her. So I was called in just to run down the hall real quickly and offer support. It became very clear to me that this was a Hmong woman. We had a fairly large Hmong population immigrate to the area. And so I was able to get we had a whole panel of interpreters appropriate to each language. We got our medically trained Hmong interpreter in. Time lapse while that's happening and the patient is still refusing care. Once we had a translator, we realized that in this patient's value system, a male provider was unacceptable. The additional issue was that she came from a background of traditional, more herbalistic, non-Western medical care. And so she had no idea what was going when the staff was trying to hook her to the various monitoring machines and take her blood pressure and so on. The translator helped us transition long enough to find out from the woman that she had an adult daughter who actually had her medical power of attorney. And so she came in and the outcome progressed well. I had to bring in one of our female emergency physicians who was not on rotation, got a hold of her, asked her to come in. She did. We had one male nurse. We had him attend to other patients. So we had an all female team that then took care of this elderly woman in the presence of her daughter who had medical power of attorney. So you think about all of the convergence of ethics just in that one single incident. You have surrogate decision making. You have the whole social and cultural and racial and ethnic groups and so on. So you would encounter a lot of that in an acute care setting. And even with the PA program's primary care focus, in a region with diversity, you're going to find in our region indigenous patients, patients of color, immigrant patients, older patients, younger patients, and so on. So you're going to have a pretty significant role of diversity. So what I'm going to do is to pause here. I'm going to stop the share. I've got a blank slide I'll put up so I don't lose track where I was. And then I want to take a few minutes and talk about a case that emerged when I was on duty in the ER that captures a fair amount of the ethical decision making in a real life kind of circumstance. So from the beginning, what we had is we had a patient present in the emergency department, I shouldn't say present, arrive in an ambulance after a traffic accident. She had hit something head on. We didn't have the details at that point. Impacted the steering wheel, no seatbelt use, and had flail chest. So multiple rib injuries, crushed chest. She was oriented to place and time and was refusing treatment. So at that point, the refusal of treatment triggers our protocols. Administrator on call arrives. So my first obligation was to ensure that I had a competent patient there that I was visiting with. So, I'm fully masked, I'm gowned, I introduce myself, I put my name badge on the outside, and I go through the structured process of ensuring that she's oriented to place and time and that she appears to be competent. And she continued very clearly to say, I do not want care, I don't want anyone touching me. So I'm going to pause. What do I do? I'm an administrator, I'm not a clinician. So, what's my advice to the clinical team? Somebody jump in. We've got a patient on the table. She can't wait. Come on, I know you're not that shy. Go ahead.
If it's life, limb, or eyesight, does her denial, what trumps her refusal of care or life? I don't know.
Okay, that's the fundamental issue because clinically my team has said if we do not treat, she will die. So it's a life and death circumstance, and it was a very real one. The adrenaline is going like mad and you're trying to make a good decision, but you're doing it in a specific context. So what's my context as an administrator as I'm turning to advise my medical team?
I don't know if this is what you're asking about, but I think you might be asking about what your lens is on the situation and what your lens brings. So like you would need to consider your own personal perspective and bias and how that might impact the situation. So you
Okay, so I admit I set you up for that, but no, remember what I was saying about the organizational context. My personal value would have been to tell my team to intervene because that's why we're there. That's what they trained for. That's what the hospital exists for. But I don't have that privilege. So why could I not act on that? What is my broader context? It's very fundamental.
It's her
Do no harm.
right to refuse.
Yeah, it's her right to refuse. Because in, not acting, we are in effect doing harm. So we don't have that option. But it is the patient's right of self-determination. Now that's both in law, and that is a fundamental moral principle that a competent patient dictates their own patient care. Now, as far as we knew, there was not a, medical power of attorney issued or anything else. So this is a point in time you're making decisions with the information available to you. And so I have to tell the team, this patient is oriented to time and place, appears competent, and it is her expressed wish on the record, because we have, the nurses recording it all and it's being charted, that she denies care. Okay. So the process pauses. The team is very frustrated, rightly so. That's not what they're there for, is to watch someone die. And as administrator, I'm gathering more evidence because, rational people typically do not say, don't treat me for something that could in fact save their life. So clearly there's some other process, in my opinion. This is where my value system comes in. So I go out and I talk to the ambulance crew. They don't have any information. There was a traffic accident. They picked her up. She had run into like a bridge abutment. Did not wear a seatbelt. So that's all they knew. Then the officer who was first on the scene arrived in our ER, which is the protocol. They follow up. They follow the ambulance once they've cleared the scene and gotten other officers in place. And at that point, the officer reports to me that he thinks it was intentional. No braking marks, no apparent attempt to steer away. So he thinks it's intentional. So that's my first indication that this may have been a suicide attempt. Well, meanwhile, the patient has lapsed into unconsciousness. And of course, the clinical team, being trained the way they are, is saying, okay, now she is not conscious and therefore cannot assert her right to deny care. We should intervene. So I'll pause again. The seed has been planted that maybe this was a suicide attempt. The patient is unconscious. What is my obligation as an administrator?
Could you argue that she's not in sound mind, so then you can provide medical treatment?
Very tempting. And that would have fit my values. But what would my record say? If someone went back and looked at the medical record, the last entry was that she was competent and he expressed a desire not to be treated. So what has happened is she has followed the natural progression of not being treated and lapsed into unconsciousness. But that apparently cogent and proper informed consent, or denial, I should say, of treatment still holds. So I have to tell the team, no, we can't play that game. Just because she's no longer able to assert what she has already asserted in our charting, we can't make the decision for her. So with the officer's report, we do a lot more outreach and investigating. And, this is a span of time that I'm talking about. We get a hold of an adult daughter. And she comes rushing in. She had not heard about it, but we have a problem. She does not have medical power of attorney for her mother. So she is by law not able to substitute her decision. However, she does bring in the information that her mother has been treated for depression, was on medication, stopped taking her medication, has verbalized suicide tendencies, and key piece, she gave us the name of her treating psychiatrist. So now that's a game changer. I have somewhere I can go from a legal standpoint to follow through on what I think is a more proper decision morally with my own values. We do then reach out to the attending psychiatrist who substantiates that this was a suicide attempt, and he rushes in. So now we have an attending physician with responsibility for the patient who is able to verify on the record that the patient was attempting, in his professional opinion, the patient was attempting suicide. And therefore, in the state of Wisconsin, since suicide is not legal, she was not competent to make that decision. All right. So now what? What do I do?
Authorize your team to.
Bingo. Yeah. Now I tell my team, all right, under medical authority of this physician who has attended the patient, and based on this professional judgment that she in fact is not competent to have denied treatment, go for it. And they were able to do the treatment, recover. She was discharged not terribly long later. She was discharged into the care of an inpatient psychiatric unit. And the story ended for my hospital and our team. So we've had a transfer of care to a different facility. Now, just because people like endings, I did hear later through about third hand that she had recovered back on her meds, and at least the last story I had was she was doing much better. But that's okay. That's one case that shows the kind of dilemmas that we run into on the fly in urgent care, in acute care, and that it's very probable if you're a frontline PA in a rural setting, if you're covering the ER on a rotation, whatever it might be, you're going to face this issue of informed patient consent and the patient's ability to say, enough, I'm not going to go for care. And where it's likely to show up, I think, in PA practice is near end of life, where someone might have a cancer diagnosis, a very poor prognosis for some chronic condition, whatever it might be. And in the course of your caring for them, that patient may say, enough, I'm going to stop doing what it is you are recommending I do. So let's talk about that just for a couple of minutes. How do you feel about that? Because this is one of the realities of primary care practice as patients reach the end of life or have some kind of poor prognosis condition.
I think, however, you can maintain dignity is probably the biggest factor.
Okay, I like that. You know, as someone who is a little later in life, that's pretty important to me. I do have medical directives, and ironically, as I was preparing for today's session, my wife and I were chatting last night. It's time to update them. We have an adult son now that we want to make to give our medical power of attorney. So we're going to update our directives and make sure that our physicians and so on have them. Many patients do that. That is the current really encouraged practice. Some patients won't. So, you know, you may find yourself in the kind of dilemma that I faced where someone had not thought ahead, apparently thought they were immortal or didn't care or were afraid of the system, whatever the rationale, and had not made those kinds of decisions, did not have a designated decision maker for medical care. Other reactions. Okay, I'm going to shift gears then to a case out of our ethics panel that illustrates sort of the challenge between patient self-determination and our legal system of rights versus what's beneficial for the greater good. So one of the things that our hospital had was the regional neonatal intensive care unit, which meant that we did a fairly high proportion of high-risk deliveries, and that sometimes meant some real high-risk babies. So we had a young couple, fully insured, which is a key part of the story, who she had suffered a very difficult pregnancy. Her baby was delivered incredibly early, taken directly to the neonatal intensive care unit. But they were concerned about whether that was the right decision. This was a profoundly disabled newborn, and her pediatrician, personal pediatrician, her OBGYN, and our own director of neonatal intensive care all gave her a very poor prognosis for the infant, life expectancy counted in days, at the most weeks. So she and her husband asked us to convene our ethics panel very quickly to assist them in making a really tough decision. So we simply maintained the newborn's life, doing sort of minimal interventions. Our ethics committee was always 24-hour on call. I chaired it, or one of my administrative team if I was not available or whatever. We always had an administrator. We had someone from the nursing team. And again, we had sort of a designated panel, so we always had someone to cover. The hospital had a legal firm on retainer, and we had 3 qualified attorneys available from that firm who would be the legal advisor. We had an internal chaplaincy program, and so we had a chaplain, so we always had a clergy perspective, and we would offer whoever was requesting the panel to convene the option of having their own clergy if they had someone that they would like to be a participant. So we convened the panel, and the couple, sits in because they are asking for guidance and advice. So we had the clinicians present first. Here's the case, here's the prognosis. All 3 of the primary attending specialists were in agreement that the prognosis was such that the infant would not survive. Maybe not, but they were unanimous. This infant cannot survive given the profound nature of the problem. The clergy advisor, who was our own chaplain, sort of took them through some of the moral and religious values, and basically was saying, based on your faith tradition, perhaps you can hope for a miracle, but your factual basis is such that that can't happen. And even if there is a miracle and the infant survives, it will be profoundly disabled. So those were the realities that this couple faced. And then I had probably the worst task, in my view, in this emotionally charged thing of talking dollars. So I took them through, if it's a 1-month stay, it's going to be something in the range of $300,000, $400,000 back at that time. For neonatal intensive care, it's 24/7 care with an entire team, a very expensive unit. And excuse me. So they had good health insurance. And so the husband's immediate response is, well, boy, we would only have a 20% copay, and our maximum out of pocket would be whatever number it was. And so then I had to present the greatest good argument, and that is, yes, your out of pocket would be that limited amount. What you need to think about is the greater good, because this would then be approaching a $500,000 claim on your employer's health insurance plan. And that almost certainly would trigger a future increase in health insurance rates for every employee. So you have to decide if that's worth it. Is it worth it to have a binding experience such as it would be in a neonatal intensive care unit, which is gown, gloves, and working into a bassinet or a isolette, I should say, whatever. Not much of a bonding experience, but that's what they wanted. So regardless of our personal values, and in this case, I was looking at that greater good, knowing the cost and the impact and the apparent futility of spending that kind of money and that kind of emotional cost, only to have the prognosis play out just as predicted. Ultimately, they decided to do that. They decided that it was worth it to them as a couple to have whatever limited time they would have available and pray for a miracle. So, what's your reaction so far? And then I'll give you the outcome. Very predictable. How would you have advised if you were one of the clinicians involved in this case? Very real case, very, very daunting case. I've never forgotten it.
I think my first reaction would be concern for the infant's level of pain or distress they might be in these few weeks or maybe even a month that they do live, since they're growing up in an incubator and hooked up to things.
Okay, that's an excellent point.
When you were talking about the greater good argument, you could also argue the fact that these services will not be given to another infant that could potentially have a higher likelihood of a positive outcome.
Yeah, another good point. I didn't need to go there in this particular case because, based on our usual trends, we had sufficient capacity. But that would have been a really good argument had we been in like a COVID area where all the intensive care capacity is getting scooped up. Other comments?
I would maybe want to have a conversation with them about what they would get out, what would be different for them, based on what outcome would be different for them based on what choice they made, like what would come from having that time. Just as a curious question, not even as a leading question, but if it's just about how much time they need to process that, and then if they can reflect on that, maybe they'll realize they don't need that much time. But
yeah, that's a really interesting point. I really had great respect for our chaplain, who very gently took them into that conversation. My dad happened to be a Protestant clergyman, and so I grew up in a clergy family, and he continued his ministry way up into his 80s. So I sort of, I had a feel for how those are handled, but our chaplain did a wonderful job without any prompting. And the couple, I think they really thought it through, but they were emotionally locked in to having the mom having carried this infant and dad having been supportive, and to have it end abruptly, they just emotionally were not prepared for. Other comments?
I have a question and a couple of comments. One is the issue that they needed to withhold any treatment, to just stop all treatment, and was the baby being kept alive with extreme life-saving support, or I'm not sure what exactly was being asked for the parents to do in this situation. I wasn't clear on that at the beginning. And then I have a
Okay.
couple comments after that.
Okay, so let me clarify that. For a very short span, while we convened this group, and it was really fast moving, we got people come to the hospital right now. We did a limited amount of intervention for a newborn who could not sustain breathing and cardiac function without mechanical assist. I don't know the clinical details, but a significant portion of the brain was just missing. So it was a pretty profound issue. So yes, it was to end the intervention, which in limited circumstances at that point in time, the law permitted that. So it was, do we admit, and that was the key technicality. We were doing the intervention still in the delivery room, and we had not admitted the infant to our neonatal intensive care unit. So essentially what we were arguing to finesse the law is that this was post-delivery care in the delivery unit. You know, kind of a gray area, but we wanted to go there to give this couple at least time to have the conversation with the ethics committee that they requested. So that was the framework. Do we admit to the NICU and begin the formal intervention? So what's your question following on that?
Well, just in talking about, like you were saying that you were taking this couple to a hard place and a hard conversation to have after giving birth. And I'm not sure whether they knew this was going to happen or was this a surprise at delivery. I suppose the preterm would have been a surprise, but I don't know if there was any other abnormalities. But I can speak to as a mother that yeah, that would be a hard decision to have a parent make. And I think sometimes it's hard when you're given a choice as opposed to just something being done for you. And I know for me personally as a parent, that would have been the hardest part of it is having to make that choice.
Yeah,
Both of my girls too.
that's a tough one. There were some indications from some of the amniocentesis. The pediatrician had prepared them for a disabled child. There was not enough diagnostic information at that point in time. Now you'd have better medical ultrasound and other imagery that probably would have helped the decision, but they knew something was going to be a problem. They didn't know how profound it would be. As to making the decision for them, that would have put us in a real tough spot because the parents are the decision makers for the infant. And as a healthcare system, we can't substitute our judgment for the appropriate patient advocate, which would be the parents in this situation.
Yeah, and
So
I didn't mean that I didn't mean it to sound like that you should have made the decision, but just saying as a parent, that might have been what was very difficult too, was as
yeah,
opposed to what do I get from keeping my baby alive, other than just I can't choose this. I can't choose to end that. I mean, it's sort of like, and this is a totally not even acceptable example maybe, but I have a dog that we kind of are in the same boat. Like it's, I just can't bring myself to make that decision. I just kind of wish she would go naturally.
yeah. Well, I don't want to go on a tangent, but I'm a dog person too, and we faced the same decision with a dog that we had for 18 years. So, yeah, that's a reasonable analogy in my mind. Yeah, it was really tough because the clinical team they knew. I mean, they were unanimous in what they thought the outcome was, and they really, they started the conversation before the rest of our team arrived. They came to my office and said, "Is there any way we can not act? Can we just let nature take its course? Because this infant will not last long." And you can't, because the family is there and they are able to make the decision by law. It's their decision to make. So, yeah, it was tempting, knowing the cost and knowing the prognosis and what they were facing. But ultimately, and, I'm kind of watching our time here. ultimately, the couple decided, yes, we want whatever time is available. And as it turned out, it was roughly, I think, about 3 weeks, as I recall it. And yes, the bill was right in that $500,000 range. And so, if they had even a 10% copay, they paid an awful lot for 3 weeks of emotional support via gown, glove, and in the the isolate. I don't know. It's not a decision I would have wanted to make, and I think I probably would have reached a different decision if my wife and I had faced that. But it was theirs to make. So to me, that's a really challenging case, and it's the conflict of our societal greatest good for the greatest number and society's dictate that the patient governs their own care. And in this case, the parents govern the care of a minor. So, those are a couple of cases that I can bring you from my hospital background. We have about 10 minutes to go, so I thought I'd take us through some of the PA standards and talk just a little bit more, unless you have other questions about these cases.
I guess I have one more question about the case.
Sure.
I just am curious how you think this would have been likely to play out in a different health system. Like, I think our country's health system is pretty unique globally. And so sometimes it's hard for me to suss out, like, so many of the decisions have money as one of the core pieces. And would that play into things differently if this case were in Canada or somewhere else?
I would say yes, it's very likely it would have, because Britain's system, Canada's system, most of the socialized systems have a fundamental structure that works off the greatest good for the greatest number. So to look at the opposite end of the age spectrum, one of the things that my hospital had was an extremely active hip and knee replacement practice. So we had an orthopedic surgeon who only did hips and knees. He only used a single medical device for implant, or brand of device for implant. And just to give you a feel, so we had one OR dedicated to his practice 3 days a week, 2 adjacent rooms with a sterile pass-through in between. He had a primary care physician and then later a surgical PA who would do the prep. So literally would prep the patient, start the anesthesia, open the site. The orthopedic surgeon would scrub in, do his carpentry thing, which I always accused him of being a glorified carpenter. He never seemed to appreciate that. I thought it was pretty funny. So he'd go in and he'd do the actual joint replacement. He'd scrub back out, move to the other OR where his second patient was waiting, open and prepared. And the primary care would trade sites, scrub back through, come and close the first patient. And they would go back and forth all day. Now that was, at that point in time, roughly $7 million practice in a year. So that's sort of the opposite end of the spectrum. And the reason I bring that up is that he would take patients way into their 80s and even some patients in their 90s that his orthopedic colleagues would say, ooh, man, we really want to look at these cases. So they were constantly kind of on him for his patient selection. That would not have been allowed in Britain at that time or Canada. They had age limits and you just, you didn't get joint replacements if you were over 80, period. Because the cost is higher. The lifetime return is obviously shorter given life expectancy. So, yeah, other systems would have had definitely a different conversation and probably a different outcome. And I have to put it in context. So you've gotten me on my soapbox a little bit. The US healthcare system has marvelous features that I just am delighted with. We have best technology, we have incredibly talented clinicians, but as a system, we pay more per person than any other developed nation or any other nation, period. And we have middling to poor outcomes across most of the measures, like, you know, prenatal care and some of those preventive things and so on. You know, within the OECD nations, we rank as low as 40th in some of those measures. So we're paying an ocean of money for a system that delivers extraordinarily good care for fully insured, et cetera, and not so good if you're indigent, if you're not into the system, if you don't have good insurance for preventive care and so on. So, you know, there is a dilemma, a system dilemma that we have in the US that, you know, keeps being talked about in the policy making circles, and we haven't quite found the solution yet. So that's a long answer.
That's a thoughtful response. Thank you.
Yeah. Okay. So I show 3 minutes. So I am not going to take you into your PA statement. Please be sure you look at the ethics of the profession. They're very traditional, very foundational. I think they should guide you well as you enter into practice. But, you know, if you get only a couple of messages out of this, one is make sure you're choosing the right practice when you leave, because there's nothing worse at the individual level than to end up in an organization where you don't believe in their values or their mission or their approach to care. That's a fast track to burnout. So, you know, make good decisions as you're looking at practice opportunities. And I frankly, at a personal level, I hope to see you in one of those practice settings. I'll share very quickly that I had an appointment for primary care. I kind of crunched my leg a little bit at the beginning of the year. And the nurse practitioner asked, you know, I've got a student following, would you object? Well, you know, Dean of Health Sciences, no, I'm not going to object. But the penny didn't drop on who that student might be until one of your colleagues walked in with her lovely Saint Scholastica lab coat on, white coat on, and observed. And, you know, it was a short-term appointment on short notice. So there was me as the dean in my grubbiest grubbies and hadn't had time to shower because they said, oh, we can get you in right away. Yeah, and in comes one of our PA students, very professional. And I hope that you bring that same level of professionalism when you reach your clinical year. I've got great faith in you, and I think you're going to have a great future. But please pay attention to the ethical dimension and the values that you hold and your future organization holds. So any final questions? Okay, well, thank you so much for the opportunity to chat with you about this, and I hope I've triggered at least some thought. You're in a marvelous profession, you're on a great track, and I look forward to seeing you in practice throughout the region. So take care, have a good rest of the day.
Thank you.
Thank you.
Thank you so much.
Yeah.
Thank you.
Thank you.